take 57. So we have a really big case today, and this patient is going to be receiving a central line as well as an arterial line. Before I even go and talk to her about this procedure, I'm going to ensure she doesn't have any contraindications that would preclude us from doing them at all. So one absolute contraindication would be SVC syndrome. Some relative contraindications would be uncorrected coagulopathies, carotid artery aneurysm, or infection at the site where we're going to be going. She doesn't have any of those problems, so I'm going to go ahead and introduce myself and talk about the case. Good morning, my name is Marley. I'm a student nurse anesthetist, and I'm going to be in your case today. And I just wanted to ask you your name and date of birth. Okay, and what kind of surgery are we having today? Okay, patient has been identified. Okay, so I just wanted to come in and talk to you about that line we're going to be putting in your neck. It is just a big IV essentially, and it has 3 ports on it, and so it helps us in administering lots of fluid at one time if we need it, while we have 2 other ports for other drugs if we need to give you other drugs. It also protects your smaller veins since it is a bigger IV from vasoactive medications that we anticipate on giving you in this case. So those vasoactive medications, they really clamp down on those smaller vessels and can cause a lot of damage. And so we want to prevent that at all costs with that bigger IV. An alternative to this IV would be just to use those peripheral veins, but like I said, it's just very, very dangerous for those smaller veins, and I would personally not feel comfortable proceeding with the case without that bigger IV, just to not only the drugs, but your hemodynamic stability. So some risks involved. Anytime there is a puncture at the site or at the skin, there is a risk for infection. There's also an inadvertent risk of inadvertently puncturing your lungs or your carotid artery, which sits very close to your jugular vein. And so with all that being said, I would do my best to mitigate all those risks and to ensure that you are as safe as possible whenever you're under my care. So do you have any questions, problems, concerns? Okay, I answered all the patient's questions, and they have consented to the procedure. So with that being said, I'm going to go and prepare myself. So I just want to make sure I have all of my supplies. I have my kit, I have my PPE, mask, gloves, and then my sterile gloves and gown for later, and then my pen to mark the patient when they come in here. So I would definitely want to consider some type of sedation, possibly Versed 2 milligrams IV. But since I do plan on putting this in while the patient is already under general anesthesia, that will not be necessary today. So I'm going to go ahead and put my mask on, get ready to enter the OR. Just some gloves. So at this point, my patient is under general anesthesia. I'm going to position them in a slight Trendelenburg position, head turned to the left, really exposing that right neck. And so at this time, I'm going to palpate the carotid artery, looking for my landmarks. So my landmarks here, I'm looking for the sternocleidomastoid muscle. With the sternal branch is more lateral, or more medial. The clavicular branch is more lateral, and so lateral from the thyroid cartilage over in between those 2 muscles is where I anticipate on going. So I'm going to go ahead and mark that with my pen. Okay. So now I'm just going to get myself prepared here. This will be trash. So sterile prep. I'm going to clean really well from the mandible, tragus of the ear, all the way down the neck, scrub, 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 all the way down below the ipsilateral nip, over to the side. This large prep is to ensure that if I'm having difficulty with the internal jugular, I could move on to the subclavian vein. But that will not be necessary today. So the patient is prepped. At this point, I'm just gonna remove these gloves and put on the rest of my garb. As sterilely as possible, I'm going to put on this gown. However, it is not technically a sterile gown. But for these purposes, we're going to pretend. And I'm going to ask my assistant to please tie the back. Okay, I'm now going to don my sterile gloves. Which have also been used. So this might not be as graceful. Just trying to save resources, Dan. Okay. Bring that down as low as possible. Okay, I'm going to prep the patient, drape the patient, remove the sticky, head down, dropping this onto my marked site. Okay, and then kindly asking my assistant to help me drape to avoid breaking my sterile field. Okay. Neck is nice and exposed. So at this point, I'm just going to take a look at my kit and get everything ready to go, so I'm not fumbling around with it when the time comes to need it. So my guide wire, make sure that that works properly. Remove the cap. Set that here. I'm going to drop my lidocaine with a blunt needle. So we'll say it's drawn up into my, and then I'm going to attach my 25 gauge needle for my skin wheel. Okay, so that's ready to go. I'll be needing that first. Okay, I'm going to, rather than using my finder needle, I'm just going to use my introducer needle, being very careful, palpating the carotid pulse the whole time. I'm going to remove the cap so it is ready to go. Introducer is within reach. My catheter is uncapped, and at this time I could flush all of my ports if I wanted to, but I'm just going to use the free flow of blood method and then aspirate and flush when the time comes when I do have a good backflow of blood. I have my scalpel ready. I'll need that right there after. Okay. I think I'm ready for my skin wheel. So, palpating carotid, aspirating for blood, injecting as we go, just to ensure that we are not intravascular. This is just skin wheel. Okay. So at this time, I'm ready for my introducer needle. I'm going to keep my hand on the carotid pulse the whole time while aspirating back on this needle. And I'm going to go in towards that ipsilateral nipple. And I do have good free-flowing blood. It is very dark and non-pulsatile, indicating it's venous and not arterial. Okay, using my bromage grip, I'm going to stabilize that. Okay. Going to advance my guide wire to about 20 centimeters. Watching for ectopy on the monitor. If I did encounter ectopy, then I would retract the guide wire. Okay, I'm at 20 centimeters. Being very, very careful with my guide wire here. Okay. At this point, I'm going to retract the needle off of my guide wire while putting a little bit of forward pressure. Okay. So now I'm ready to make a little incision. Okay. Now I'm going to use my dilator. And this is really just to dilate the surrounding skin, not necessarily the vessel. So I'm only going to go about as deep as I went with the needle. Okay. Going with my catheter, my patient is 172 centimeters, and so I'm going to go to about 17 centimeters. I will be looking for the guide wire to come out of the brown port. Which it is here. I'm just going to stay on this side. Okay, we'll say that's about 17. These mannequins, I just don't want to have a hard time or mess it up. So at this point, I will remove my guide wire carefully. That will go into the sharps. Say that's over there. And at this point, I have free flow of blood, I have a little bit of backflow, and I'm going to take each of my ports here, aspirate, flush, clamp, and then I'll be putting on my cap. Okay, and I'll just do the same thing for each of these. Aspirate. Oh, nice. It's in there. Okay. Aspirate, flush, clamp. Okay, roll clamped. Okay, so at this point I can suture my line in place and maybe like so. Make sure I have an occlusive dressing. Get a chest x-ray to ensure that there is no pneumothorax and that it is in place. Also, I would monitor vital signs and just monitor the patient Q5 minutes for 15 minutes. But since we're already in the case, it's just going to be constant monitoring. And document and proceed. Okay, so at this point our central line is in, and for this case we're also going to be needing a radial art line. I've previously explained to the patient that this is indicated for labile blood pressures that are expected in this case. It'll be good for a second-by-second monitoring of blood pressures and titrating any drips needed. An alternative to that would just be continuous blood pressure cuff cycling, which can be uncomfortable for the patient. Some of the risks involved would be a clot in the radial artery, which could cause some ischemia. Some other risk would be infection, bleeding at the site, things like that. So since I've explained it to the patient, she has consented to the procedure. So we're going to go ahead and get started, starting with the Allen test. So if the patient was awake, I would have them open and close their hand to exsanguinate the blood from the hand, but since they're already under general anesthesia, we don't need to do that. I'm going to occlude the radial artery and the ulnar artery at the same time. looking for the hand to become white. I will release the ulnar artery, looking for the hand to pink back up in 5 to 7 seconds. If it did not, if it took maybe closer to 15 seconds, then that would indicate poor collateral flow to the hand through the ulnar artery, and it would not be safe to place a radial art line into this patient. So now that that has been confirmed, I'm going to go ahead and position the patient with the fingers back, thumb up, to really expose that radial artery. If the patient's anxious at this time, I would give a little bit of Versed, but since, like I said, they're already under anesthesia, it's not necessary at this time. So I'm going to put my gloves on first before I clean. Okay, so now I'm going to clean. Get it nice and clean. Put that in the trash. I've drawn up some lidocaine 1% with a 30 gauge needle. I'm going to do a little skin wheel. It'll make it a little bit better for the procedure. That'll go in my sharps. At this point, I'm going to use the skin pad to visualize the guide wire a little bit better. So I'm going to move this guy out of the way a little bit. So this will kind of help with any bleeding that might occur, which is to be expected. I'm going to inspect my needle and guide wire, make sure that it threads easily and it's bevel up. So holding it like a pencil and palpating the radial artery, I'm going to go in at about a 30-degree angle. Once I see flashback, I'm going to drop the angle and advance my guide wire, and then advance my catheter. While occluding distally, I'll remove the wire, placing that into the sharps, looking for flow. I would attach my pressure tubing, transduce it appropriately at the phlebistostatic axis, look for an appropriate waveform. At that point, I would be able to suture it in place for a longer case, and then pad the hand and place an occlusive dressing. Document that this has been done, and we're good to go.